I'd like to now invite Dr. Subhadra Jalali, whose passion and interest in ROP is so infectious that she's really brought about a revolution, and we are grateful, ma'am. We will be changing the order because two of our speakers are also in concurrent sessions elsewhere. Dr. Jalali is going to talk to us about the long-term outcomes of ROP, but also the important differential diagnosis.
Hello everyone, thank you for being here. So I'll try to be brief. You know, the pediatric retinal pathologies, all of them can mimic ROP, and sometimes we miss them. So different stages of ROP can mimic a different course of the disease. But I will be, highlighting more about the vascular lesions and a few others. So as far as the neonatal vascular retinopathies are, we know about ROP, FEVR, which is a close mimicker, Coats disease, ROPER, which is a new entity where a preterm baby looks to have ROP but actually has a morphology which is more like FEVR, and then of course a lot of syndromes. The challenges are that unlike the adults, we don't have a lot of tools to evaluate the retinal vascular pathology in these babies. So what is different in retinal vascular pathologies of infants is that the infantile retina can stretch as it is elastic, just like the infantile cornea can stretch, but it doesn't stretch beyond the toddler age. So all these retinopathies are very rapidly progressive in babies as compared to adults. And the potential for vision progressively declines. So these are emergency cases, have to be handled as emergency, all these retinal vascular pathologies. So I'm just showing some pictures that how the retina distorts. So if in an adult you see a disc drag or a macular drag or a fold, then you know that the disease actually started in the neonatal period, because after infantile age it doesn't happen. And the configuration of that fold would depend on whether there was a persistent fetal vasculature stalk or not. You can see if there's no stalk, then only the periphery will fold. If there was a stalk, then the central macula will also fold. And you can see here different diseases can be with or without this persistent fetal vasculature stalk, and this should be taken into consideration when you're looking at the differential diagnosis. So if you have a baby who looks little different, for example here you can see there are new vessels, but there's no plus. So then it should alert you that why there's no plus, because stage 3 should be always accompanied with plus. Then you examine the mother and you find that she is blind in one eye and has exudation in the other eye. So then you know that this is FEVR and it is not ROP. Same way, if you see very fulminant disease very early on, so this is like 2 weeks babies or 3 weeks babies, they are born with a white reflex on the day of birth, then this is not ROP. The ROP leukocoria detachments will occur at 2 or 3 months. Even for stage 1 disease, the leukocoria will happen at least 6 to 8 weeks down the line. So the timing and the tempo of the disease will tell you that this is FEVR. The other important thing is that as soon as you see this disease, just go ahead and operate. Send them somewhere who can operate within 2 or 3 days. I have seen patients having had a fundus photograph done on day of birth or 2 days, somebody picked it up and told nothing to be done. You can see here, even if there's a small stamp of retina which is spared because they have dysplastic retina, this child actually has 2300 vision at 20 years of age. This is almost 20-year-old slides. Even a few hard exudates, just 2 or 3 yellow dots in the retina can tell you that this is FEVR. So look for these yellow dots. Whenever you see yellow dots, this is FEVR. Coats disease, we had the opportunity to see a Coats disease. This patient seen by my fellow called me and said, I have seen ROP in only one eye. You always tell me it's always bilateral. I said, no. If there's no posterior pole change, which he was describing, there's no posterior pole dilatation, toxicity, this is not ROP. And when we saw, of course, this was Coats disease, and it worsened in next few weeks. And we had to do repeated laser every week for the new lesions, which is very unusual. But yeah, you can have Coats disease. Then you can have systemic disorders like incontinentia pigmentosa and so many others where you need to do the screening, and they can have subtle changes, and they need laser very early. Now, whenever you have retrolental fibroplasia, these all children get referred as retinoblastoma to our oncology, and many times they have enucleated these eyes. So how do you differentiate? I think the history is critical. If there's a history of prematurity, then think of ROP, especially if they had multiple other things. The eye-poking behavior, almost always when leukocoria starts, the child starts an eye-poking behavior in ROP, FEVR. It doesn't happen in retinoblastoma. You can just watch the baby and you will pick this up or ask the mother. Okay, you can see here. They will tell that, the child is not opening the eyes. Then, as I said, the timeline, when was it noticed? So the congenital retinoblastoma almost always is a macular lesion or a close to posterior pole lesion. It is not a leukocoria. which happens in ROP and FEBR. The leukocoria of retinoblastoma usually will happen after 6 months of age. Then enophthalmos. This is a very important sign. If you see enophthalmic globe, which happens because of poking, then this is not retinoblastoma. Okay? And if they say that, you know, one eye is shrinking and going inside, then usually it will be enophthalmic, and that is not retinoblastoma. Of course, you can have retinoblastoma developing as a phthisis, but there the history will be different, no eye poking behavior. If the child looks very malnourished, poor weight gain, the whole body size is very small, then you know that this is ROP, and usually retinoblastoma children are usually very healthy till they develop metastasis. So subtle findings, like if even with the torchlight you can make out that if there is a retinoblastoma, usually they will not have posterior synecdoche, they will not have fibrosis, as you see here, there will not be any scarring, they don't get this corneal scars, Peters anomaly, like secondary Peters anomaly. That doesn't happen in retinoblastoma. Of course, your ultrasound is the most important. In ROP, FEBR, you can get subretinal echoes of blood, cholesterol, which doesn't happen in retinoblastoma. Always do immersion scan in every baby to look out for calcification. You have to mention that there was no calcification. In this case, you know, this patient was you know, having some syndromic features. You can say there was no hair growth. Actually, this child has not had any haircut. She has no hair growth, and she was referred as retinoblastoma, but actually has a syndromic condition where the retina has not grown. This child, we missed retinoblastoma. It was labeled as trauma, and you know that there was something, but the B scan showed that there's a retinoblastoma, but it was not picked up, and patient, you know, came back with metastasis. So every, you know, leukocoria we have to rule out, but we have clues how to differentiate the two. Now this child I have operated for PHPV in childhood, and then comes back with neovascular glaucoma from the Gulf country, was thought to have a calcification of the optic nerve, and is it an optic nerve tumor? They enucleated the eye, there was no tumor, this was a PHPV which went into neovascular glaucoma. Of course, the other differentials like infections, CMV retinitis, HSV retinitis, you know, E. coli infection. So there are so many infections which these babies can get, and they can mimic ROP because they'll get some hemorrhage or they'll get some retinal fold. So proper history and treatments can be done. So coming to the outcomes, the CRY-RP study, as you can see, had very dangerous outcomes, not very happy for parents, where you said, you know, 50% children are going to be blind and 50% only will see little bit. And you can see good vision, 20/40 or better, only in 13% of treated controls. But that was the time when the aim of treatment was to prevent detachment. Today, that is not the aim. The aim is to preserve the excellent vision that these children have the potential at birth. So all children should end up with 20/40 or better vision if we are on time and we have treated well. And that is what I'm seeing here. This is our series of patients. Whether we allowed them to regress on their own or we treated them before they had detachment. So these are stage 3 plus eyes or stage 4 AIs where the macula was not detached. Even those who underwent surgery, you can see that less than 8% of, or you know, less than 5% of these eyes will actually lose vision. Almost everybody will get good vision if you treat them on time before the macula detaches. Even you can see the retinal outcomes, less than 5% will progress to detachment of the macula if you have intervened correctly on time, when they come to you on time. So it actually has a very good prognosis, provided you have all the tools and the knowledge and the skills to handle these babies, because they are not born blind. They're not born with a retinal pathology. Their retina is completely healthy at birth and only develops problem later. So if you pick them up at stage 2 plus, before the retinopathy has gone into a vitropathy, and treat with laser injection, follow up, do the surgery as soon as the traction develops, there is no reason. But of course, myopia, glasses, is a part and parcel of premature birth. From day 1, we inform the parents, your child will need glasses, so that they are not disappointed later in life. You can see here, you know, almost everybody, even those who are spontaneously regressed, -2, -3 myopia. Of course, they don't get very high myopia, but a few patients can get very high myopia even without ROP. And once they have ROP, almost all of them will need glasses. Most of it is myopia. It is lenticular myopia. Thank you.